These are my disclosures. Those of you who are interested in unicompartmental disease, I was lucky enough to be editor of Orthopedic Clinics in North America 6 years ago, and we went through most everything you're going to hear about or you have heard about today in this particular journal. The incidence in the UK and the USA from 1998 to 2005 has increased at a rate of 32.5% compared to an increase in TK of 9.4%. So this data suggests that approximately 8% of all knee arthroplasty procedures are unis in the United States today. The classic clinical indications for unicompartmental arthroplasty are relatively sedentary occupation, less than 10 degrees of varus, range of motion greater than 90 degrees without flexion contracture, medial instability only, osteo or post-traumatic arthritis, obesity is a question mark, and I'll come back to that in a second, and unicompartmental pain only. This is called the one-finger test, and when I see a patient who has this x-ray on your left, and if they can point to it with one finger when I ask them where their pain is, then they become a candidate. If they do this and they can't localize their pain, I certainly will not consider unicompartmental arthroplasty. So the classic contraindications are rheumatoid disease, non-localized or generalized knee pain, a decreased range of motion with a flexion contracture, an active lifestyle, an unstable knee, and obesity is open to question. This was first raised by Adolph Lombardi in 2005, and he published a study in which he said the only increase in failure mode using various prostheses in only a few patients, which were 79, was obesity. And then Hamilton came along, the Academy in 2008, and said it had a questionable effect in 507 knees. Keith Barron presented this at the Contemporary Issue and Partial Knee Arthroplasty course. 2008 had 450 Oxford and said there was no effect. So I went and looked in our joint registry, and we have about 30,000 total joints now. And I pulled 921 patients with a mean follow-up of 7.2 years with a 14-year follow-up, and I'll go through that in a minute. So at the present time, this has become, for me, an arthroscopic salvage procedure. It's a great operation, middle-aged individual with unicompartmental disease, when articular surface procedures and or realignment procedures have failed. It's an easy operation for an arthroscopist to learn utilizing simple burring and or surface resection techniques. We do these through very limited incisions, no patellar dislocation, preserve the quads. You can use a burr saw, power rasp, depending on which prosthesis you're utilizing. The failure modes for these, I think, really tell you a little bit about what you need to do to make it successful. And poor surgical technique is right at the top. You have to lateralize the femoral component, put in the widest tibial component from the medial tibial cortex, the ACL, as possible. I use a Steinman pin through the intercondylar notch to retract the patella, facilitate exposure. And this is an old marmer I put in about 10 years ago just to kind of show you these are pretty simplistic, easy to do through a small incision. And that series actually did pretty well with the original marmers. You need to lateralize the femoral component because in flexion, excellent alignment is apparent with the widest tibial component from the medial tibial cortex to the ACL as possible. Note that tibial rotation and full extension occurs so that medial-lateral mismatch can occur unless lateral positioning of the femoral component and the widest tibial component is utilized. And for those of you who have done some Oxfords will know that you can't do an Oxford and lateral compartment for this reason. So appropriate femoral and tibial bone preparation results in no alteration of the joint line. This is a link prosthesis. It's called the old St. George sled. It has the highest survivorship in the world right now, 80% at 25 years, 86% at 20 years. And when you compare the Link uni to the total survivorship at 15 years, it was actually better in the Link in this series from the JBJS. Poor cement technique, I think, is critical. We have published a study Bill McShane and I did in CORE in 1998 using drill, pulse lavage, and drying in both totals and unis, and found this gave the highest incidence of reduction of liftoff and shear when checked in both totally replacements and unis. Poor component design. Choose a system with a dovetail undersurface macrostructure for the tibial component. Avoid waffles. We published this in 2002 looking at shear and offset loads. And with this dovetail interface, took about 1,200 pounds to lift this off. Waffle was about 60 pounds. And so this was our conclusion from that study that was published in the JBJS. Too much tibial bone removal. So many people think you can take a lot of tibial bone when you do these, but the problem is and I'm going to show you that in just a second. There's a good scientific reason not to do it. So here's one that was published by Brumbean, Journal of Arthroplasty. 3 more case reports are shown in these other journals, and you can see that they lowered the joint line by taking too much tibial bone. Here's the fracture through the tibia, and there's going to be your resection for your total knee, which is really kind of a disaster. Again, this was touted in this article as appropriate to place lateral component. Again, I think this is too inferior. It results from taking too much tibial bone, not taking enough femoral bone. And this one's obviously a nightmare to repair. So this is really critical to do, and I'm going to explain to you why in just a second. Here's a couple of links that I think on the right one has too much tibial bone removal, again resurfacing the femur, dropping the joint line, and obviously these two are not very well done, especially the one on your right. If you look at a Alito study, he showed at 5.6 years early medial collapse in 47%, all of which were polyethylene design, all had significant bone removal. And then this Hamlin study, again, 11% rate of subsidence in all polytibial components, but they had significant bone removal. Well, what's the problem with taking too much tibial bone? Ray Blabaum published this from University of Utah back in 95, and it was reaffirmed in 2002 in another study, is that 81% plus or minus 7% of the proximal tibia is error when you make 8 to 10 millimeter cut below the articular surface. And when you look at this electron microscopically, especially the one on the right, you can see basically what you have is a situation where it looks like Swiss cheese. Everything on the right that is white is error. So there really isn't that much tibial bone 1 centimeter below the articular surface. And if you take it another step further, if you look at the strength of that tibial bone, it's decreased by up to 29% in 2 different studies. And what about component malalignment? Obviously, this is not well done. This is a little bit overcorrect, a little bit too much valgus. Significant undercorrection can increase polywear. And if you look at this other study, 46% had progressive loss of joint space. All those patients were placed in valgus post-op. 10 to 13-year follow-up where the average post-op alignment was only 2 degrees of mechanical varus, however, only 18% developed progressive joint space collapse. So it's best to place these patients in neutral or slight varus to get the greatest survivorship of the component. When I looked at my first 100 and published this in 1998, I had an 87.5% survivorship, but 83% of my failures were due to progressive wear of the lateral compartment. John Callahan had an almost identical situation at 21-year follow-ups, as did Collier, and he presented this in 2006. Well, why do you get opposite compartment wear? Because this confused me a little bit, because a lot of the patients I did only put in 2 to 3 degrees of valgus. So I did a 15-patient biopsy study, and I found that in patients that had pristine-looking lateral compartments at the time I did their unis, still had evidence of osteoarthrosis, as evidenced by hyaline cartilage cell apoptosis, which is death, cartilage calcification, chondrocyte cloning, etc., indicating early signs of DJD in the opposite compartment. And these are patients who had a pristine, gross-looking appearance to that opposite compartment, and Moan at the Academy last year confirmed this. So finally, what about inappropriate patient selection? Well, beyond single compartment knee pain, we've talked about. This was mentioned by Scott a little bit earlier. An upper tibiaosteotomy or a UKA will not improve preoperative anterior knee pain or lateral knee pain for that matter. I get several patients that come in every year that have had unis and say, gee, doc, I'm better medially, but gee, my patellofemoral lateral compartment still hurt if they've had global pain in their knee. What about patients who are too active? Well, again, I think active lifestyles are a problem. And if you get a guy like this that just was really kind of crazy, this is not going to work very well. And medial lateral mismatch is another problem with some of the designs, and you can see this one here. This is obviously not going to do well. And what about component failure and cement issues? Again, fixation is most commonly due to inappropriate cement technique and or component design. Some of these old component failures with oxidation, non-poly cross-linking of the poly were also an issue as well. This is something I call the snowplow effect, being from Minnesota, but it is very common. It occurs as cement is pushed posteriorly during insertion of an all-poly tibial component. And if you can see this, I've circled this little piece of cement. I've had 2 of this. This has happened to me twice now, where a patient comes in with a locked knee and they have a piece of cement floating around in their joint. Bill Hamilton from this area actually had 9 of these. He presented at the Academy and recently published. And finally, what about obesity? Well, I think obesity is a problem, and I'm going to show you some studies And I really don't think the guy in the far right is a good candidate for a unicompartmental replacement. This is a study by Benuti. Primary cause of failure was obesity in his series. So I decided to look at this, and I looked at our 920 UKAs. And at this time, there were 23,000 total joints in our group. And I looked at the average follow-up being 7.2 years, and I looked at these various cumulative revision rate statistical analyses. And interestingly enough, we had previously thought that increased BMI would cause early failure as well as progression of arthritis in the contralateral unresurfaced femoral tibial compartment. Published this in JBJS in 2006. But in our registry, interestingly enough, when we used BMI of 30 being the cutoff, there was no increased risk of revisions for overweight or obese patients when compared to normal BMI patients after adjustment for age and year of index procedure, with a mean follow-up of 7.2 years and a range of 2 to 14 years. And this has been submitted for publication. So what's in the future? Well, I've been working for 3 years to try to get an arthroscopically assisted unicompartmental replacement approved in the U.S. There's 2 other companies that are trying to do this. We've been very unsuccessful with the FDA. Everybody has, because the FDA is being so stringent. I thought I was really clever doing this until Bob Bert sent me a video of Dick Caspary doing this in the year 1991 at his meeting, where he was preparing the joint surface with a burr arthroscopically using a similar type of guide and then making a small incision and implanting the component. So he was a couple decades ahead of me. And it's really interesting how nice you can get the tibial surface when you prepare it arthroscopically. And then we designed a component that doesn't have a posterior femoral condyle that you can put in through about a 3-centimeter incision. And the question is, well, why wouldn't you want to have a posterior femoral condyle? So this is the way this looks after we've implanted it and then closed the skin and looked at it arthroscopically. Well, we've done about 12 of these in Bologna, Italy with another developer, and we have 24-month follow-ups on about 10 of them. This is one right here, and you can see on the lower right-hand corner, the lateral and AP film. These patients so far, knock on wood, are doing pretty well. Agnes Kircher actually has thought about this for the past decade, that he thought the posterior condyle is unnecessary for weight bearing. After harvesting, there is a Japanese study which talks about how much stress you put on the posterior femoral condyle during gait, and it's not until 70 degrees of contact that you really put anything on it. In other words, you get in and out of a chair, it's not an issue. So he looked at 29 patients between 84 and 2000. Posterior femoral condyle was harvested for autograft replacement of defects of the femoral condyle, in other words, a mega oats. And he has had no problems associated with the loss of posterior femoral condyle with 2 to 16-year follow-ups, and this has been reaffirmed by Imhoff. So is this the future, or is this a triumph of technology over reason? If biomechanically stable, would a bicompartmental TK make sense through 2 small 1.5-inch incisions, perhaps done under local anesthesia? So try to keep an open mind and don't judge too quickly, as evidenced by this video. Do you have any sound? Okay. Thank you very much.